is acute osteomyelitis, how it presents, and how to differentiate it from a chronic osteomyelitis. So acute osteomyelitis is something which has an acute presentation of an onset of less than 2 weeks, characterized by fever, tenderness, swelling, redness. So these are the classical hallmarks of an acute osteomyelitis. So osteomyelitis can be exogenous, that is from a trauma, মানে ধর কারোর there is a road traffic accident, open injury হলো, তার ফলে তোর বাইরে থেকে pathogens ঢুকলো. So that can be a mode of inoculation. So it can be exogenous, that is from trauma or from a surgery. Surgery is anything while doing a surgery, you have to open the bone, to plate, some plating or some nailing was done, and microorganism inadvertently entered into the bone. So that is how surgery iatrogenic. Or a contiguous infection. Contiguous infection means there was an infection in the soft tissue. From the soft tissue, it spread to the bone. Contiguous means surrounding tissue থেকে যখন infection spread হয়. Next is hematogenous. Hematogenous আরেকটা হয় যেটা usually is seen in very immunosuppressed বা খুব small children, এদের বেশি হয়. মানে there was a infection inside the blood, bacteremia. From the blood, the infection spread and lodged into the bone. So that can also be a source of an osteomyelitis. So let's go to etiology. Single pathogen, hematogenous osteomyelitis in infants, Staph aureus, Streptococcus and Escherichia coli, E. coli. In children over 1 year, what are the most common organism? Again, Staph aureus, Streptococcus and Haemophilus influenzae. এগুলো নিট পিজির কোয়েশ্চেন্স, তখন এই স্লাইডটা অ্যাকচুয়ালি অনেক আগে বানানো ছিল আমার, তো but it's very important slide. মানে তোদের যদি whenever you are appearing for the postgraduate entrance exams, so these are very common questions. Infants, most common pathogen. 1 to 4 years of children, what are the most common pathogens? In adults, what are the most common pathogens? Okay. But overall, what you ask that the most common pathogen causing osteomyelitis is Staph aureus, Staphylococcus aureus. Okay. What are the organisms isolated in bacterial osteomyelitis? Staph aureus ache, coagulase negative Staphylococci ache, Pseudomonas, Streptococci, anaerobic bacteria, Salmonella, and this on the other sides, what are the most common diseases associated with? Like very common question during our PG days exam was sickle cell anemia. What is the most common organism associated with osteomyelitis? And then we have to write for Salmonella species and Streptococcus pneumoniae. So you have to find this either of these two organisms. So rare organisms, Bartonella, Pasteurella, Mycobacterium. This is just for completion's sake. Okay, nothing important in these slides. Let's go to most important epidemiology. I think we can skip this. Yeah. So where does it affect the most? This is important. So the most common bone that is affected is your tibia, because tibia is a shin bone which is very subcutaneous in origin. Just below your skin is your tibia on the medial side. So sometimes what happens in small children, especially 1 to 4 years, who are going to play outdoors and they sustain a cut. Usually these people neglect those cuts. Not an issue with the soft tissue bled, they did a local dressing. But after 10-15 days, there is huge amount of swelling, redness, tenderness. That is how that infection has spread into the bone. So tibia is a very common site for acute osteomyelitis, and it usually presents in small children age group. 2 reasons: because most of the modes of injury are usually neglected. Second, their immune system is not that much good to suppress that infection. So tibia is the most common site. Okay. So how does the microorganisms go into the bone? So this is another important slide. So pathogenesis, how do they come into the bone? For your exam osteomyelitis, you need to understand 2 types, acute, chronic, that I have told. Next important side is epidemiology, that is which age groups are most commonly affected? Children 1 to 4 years. Most common organism, Staph aureus. Which is the most common bone affected? Tibia. Now use the pathogenesis. How does the bone gets infected? So this is again an important topic. So hematogenous spread involves a metaphysis of the long bones in children, vertebral bodies in adults. Another is direct inoculation of microorganisms into the bone. There is a cut, bone was exposed, bone was exposed for a long time, microorganisms directly entered into the bone. This is another method. And contiguous force of infection seen in patients with severe vascular disease. But what is important, you need to understand why the osteomyelitis is more common in that there is a word written, see, in the metaphysis of the long bone. Why the metaphysis of the long bones are most commonly affected? Because you need to understand, I think we have a slide. Okay, I will see. So, if this is the metaphysis of the long bone, this is the whole bone, this is your epiphysis, this is your metaphysis, and this is your growth plate. In between, this is your growth plate. So, what happens in a normal bone, the blood vessels or the nutrient arteries, if you have remembered in your anatomy, all long bones receive its major supply from the nutrient arteries. So, the nutrient arteries enters into the bone and they cannot cross the growth plate. Growth plate is a barrier. So, what they form long loops of blood vessels. So, here the blood flow is stagnant, the flow reduces, and this is the ideal environment for bacteria to grow. Any foreign body in your or microorganisms in your body will grow in a space where the blood flow is stagnant, where the blood flow is not there, where the blood is not able to wash out the microbes. So, the metaphysis of the long bone is an ideal place for these things to grow and they proliferate, because you have the end loops. These are called the vascular end loops where your microorganism starts to grow. That's why metaphysis is the most favorable area of the initial start of the osteomyelitis. So, this is again very important for your exam. So, in a pathogenesis, you need to understand this. This always starts in a metaphysis. Why vascular end loops? Why vascular end loops? Because the blood flow is sluggish, the blood flow is slow, which allows the bacteria to proliferate. Understood? So, this is now what I have told, all related to the microorganisms. Now, it is not always true that if I get a cut or you get a cut, you will catch osteomyelitis, because there is something called the host factors. How good is your nutrition? How good is your immune system? So, all this is also important for the osteomyelitis to set in. Otherwise, you will just get a transient infection which will settle down with antibiotics if you are taking. So, what are the causes of pathogenesis from the systemic and the local? If you see the systemic causes, malnutrition, renal failure, hepatic failure, diabetes mellitus, chronic hypoxia. You need to have oxygen in the body. If the oxygen is deficient, again growth for the microorganisms. So, immune disease, malignancy, extremes of age, very elderly patient, very young patient. Immune system is not that much robust to prevent that infection to go and happen. What are the local causes? Venous stasis, major vessel compromise, arteritis, extensive scarring, radiation, fibrosis. This is solely for the exam purpose. If you want to take a photo, you can do it, because if the exam, the questions comes, এখন কি তোদের লং কোশ্চেন আসছে অর্থোপেডিক্স আসছে না, সব শর্ট নোট তো, all short note only না. So let's come to the bacterial factors. So I think this is you have all read in the microbiology, glycocalyx formation. So I'm not going into details because there is no orthopedics in it. Okay. So let's skip this part. Phagocytosis, prostaglandin E, this is again all microbiology thing. I don't want to go. Let's come to the pathology. This is important. So see, hematogenous osteomyelitis occur in children less than 15 years of age, occurs in the metaphysis of the long bone that I was saying before. Why? Because there is decreased activity of the macrophages, there is precarious blood supply and frequent trauma, because whenever you are going and hitting the bone, either it is your shin or just above the ankle, both are metaphyseal areas. And precarious blood supply is because of that end loop that I was talking. Okay. Diaphyseal osteomyelitis is rare, it is not that common, because earlier metaphysis, but due to growth becomes diaphyseal mostly in children. Direct trauma to the diaphysis and tubercular. If there is a tubercular osteomyelitis, then you are more prone to get a diaphyseal osteomyelitis. But the most common site of starting is a metaphyseal area. So yes, see that this is what I was talking about. Now you can see the picture, the nutrient artery is going, that is the growth plate, epiphyseal cartilage if you can see. And see in this picture, can you see the end loops? It has formed the loops. So it is where the blood goes and becomes stagnant that allows the bacteria to grow and that causes the osteomyelitis. Sharp hairpin turns, flow becomes considerably slower, more turbulent, and is an ideal area. So why metaphysis is involved? So this is another reasons that they might ask you in exam. So infected embolus trapped in U-shaped small end arteries, relative lack of phagocytosis in the metaphyseal area, highly vascularized region, minor trauma leads to hemorrhage, and there is increased resistance, and it acts as a very good culture medium for the bacteria to grow. So because they get everything, the blood supply is more, the blood supply is slow. So they are not washed away, they always remain there. Oxygen supply is not that much, ideal again for the bacteria to grow. And because oxygen is not there, the entire phagocytosis mechanisms of the neutrophils is not going to act. Because that again is microbiology, E. catherine, dicocalyx, that you people already know. I'm not going into details. Okay. So let's, I think this is the same thing that is written. So what are the hallmarks of acute osteomyelitis? What did I say right now? Hallmarks of acute osteomyelitis. One is pain, next is redness, tenderness, fever. So these are the hallmarks. Now this acute osteomyelitis have two outcomes. Either it can continue, if the infection is continuing, it will go into a chronic osteomyelitis, or if there is a prompt treatment, there will be resolution of symptoms and it doesn't progress further. What happens if it progresses further? If acute is not responded properly, or it is not addressed, or if it is not treated, what it happens, it goes into chronic osteomyelitis. But you need to understand what is the hallmark of a chronic osteomyelitis. Two terms, sequestrum and involucrum. What is sequestrum? Bol, jore bol. Very good. So when there is a continuous infection of the bone, there is a vascular necrosis of that part of the bone. The bone gets necrosed and it dies off. So the dead bone, because of the infection, is called the sequestrum. But again, bone is a wonderful living tissue. It tries to produce new bone, and over the dead bone and surrounding, you start getting new bones. And this is actually from the periosteum, because periosteum of the bone is a very active living tissue. It always tries to protect you, it always tries to produce new bone, and you start getting new bone formation, and that is called the involucrum. So sequestrum and involucrum are radiological features of a chronic osteomyelitis. But clinically, how you are going to see? Like clinically in acute osteomyelitis, I told you there is pain, tenderness, redness, swelling, fever. These are all the acute phases. Radiological features of acute osteomyelitis, I didn't tell you. What will you find in acute osteomyelitis, radiological features? Codman triangle. You can find in late features, but acute, you are not going to see much in a plain X-ray. If you are going to do an MRI, you can see a bone marrow edema, that you are going to see. But acute osteomyelitis is very difficult to pick up on a fresh radiological X-ray because the features are not that much. But if you do an MRI, definitely you can see a lot of marrow edema, you can see a lot of fluid going around, that you can see. But in the chronic osteomyelitis, you can get a lot of features. So that is what I told you. But what are the clinical features? A patient is coming to you, there will be a certain clinical feature, a hallmark that you can see from a distance and tell, oh, it might be a chronic osteomyelitis. What will you see? You will see a discharging sinus. So whenever you see there is a pinpoint sinus and through which fluid, pus, anything is coming, that means that has been there for a long time. That is a hallmark feature of a chronic osteomyelitis. So these are basics. You don't need to understand very huge. You need to understand why it is happening. You need to understand the pathogenesis, and you need to understand what are the clinical features. What is acute osteomyelitis clinical feature? What is chronic osteomyelitis clinical feature? That's what you need to understand, okay? So this slide, let's go to the previous slide. See, that is what it has been written. Tissue necrosis, breakdown of bone, continued obstruction results in avascular necrosis, and what you get is a sequestra formation. Once sequestra is formed, that becomes a chronic osteomyelitis. That is not an acute. Unless you are going to remove that thing, your patient is not going to be well. Because anything dead inside our body is going to be a harbor place for more bacteria. However much antibiotics you give, whatever you do, unless you open, take off that dead thing, that is not going to resolve. Okay. So this slide is actually regarding sequestra. Now there are different types of sequestra. Sequestra during our times in MBBS days used to come as a short note in exam. Sequestrum, short note, 5 marks question or 10 marks question used to come. So first the definition. What are the pathological features of chronic osteomyelitis? The presence of a sclerotic, necrotic piece of bone, usually cortical, surrounded by radiolucent, inflammatory exudate and granulation tissue is known as the sequestrum. So this is the definition of sequestrum. Now there can be different types of sequestrum, okay. So what are the features? Dead piece of bone, it is pale, inner margin is smooth, outer margin is rough, surrounded by infection granulation tissue. And what are the types? Ring. Ring sequestra, where do you find? In external fixator. External fixators, what you have in the bone, you get long pins that are attached. Now these pins are exposed outside and that is also inside. So through those pins, your pin tract infection continues to happen and you get ring type of dead bone. If you see a long standing patient with an external fixator gone home on external fixator for 3-4 months, you can find this. But once you take out that thing, it usually resolves. Tubular, coke and rice grain, feathery. So these are totally theoretical. So for in exam, if this comes, you have to write all this. Otherwise, it won't be a 5 marks. Sequestrum is a very common question, okay. Definition, where do you find hallmark of chronic osteomyelitis? You have to write the types, that is enough. If you write, 5 out of 5. So let's go to the pathology of involucrum. Now sequestrum is done. What is involucrum? Involucrum is the sheet of reactive new immature subperiosteal bone that forms around the sequestrum, effectively sealing it from the bloodstream just like a wall of abscess. The involucrum is irregular and is often perforated by openings. Involucrum may gradually increase in density and thickness. It is a body's mechanism of formation of a new bone, and there is exudation of polymorphonuclear leukocytes joined by large number of, so these are again theoretical. This is solely for your theory exam. But what you need to understand is involucrum is a new bone that is produced from the periosteum to protect and shield so that the infected sequestrum, the infection from the sequestrum is not able to spread outside to the bone. This is body's defense mechanism. So you always see sequestrum and involucrum together. Inside will be sequestrum and outside just to protect it so that the infection doesn't spread to the other parts of the bone. You have an involucrum. But in long-standing cases, if the clinician is not able to pick it up or the patient is not going to seek treatment, then the entire bone can also be infected. We have seen cases where the entire bone is infected and then you don't have much option and you don't have anything to do. So those are difficult cases to treat. So very, very late presentations. So these are the features, local signs for acute osteomyelitis, okay? The same thing that I have told you. So there will be heat, red, pain, tenderness, swelling. So the lesion is within the medullary cavity, there is no swelling, soft tissue is also normal. These are very, very initial stages, okay? Deep tenderness, if you go and put pressure on the bone, you can feel the patient is having pain. That is what tenderness is there. So these are again something which I have already told about. Clinical picture, patient will be very toxic because you can understand there is an infection going on. Any patient in infection will have all the features of toxicity. They will have pain, they will have fever, their counts will come high. If you do a lab investigation, total counts will be high. Okay. So this is all very discussed. So laboratory findings, see white blood cell count, the total counts, leukocytosis as high as 20,000. If you do a blood culture can show bacteremia, can even show the species if what infection is there. You can do an aspiration. Nowadays we don't do much because it's become more of a clinical diagnosis, and with new investigations like MRI, you have technetium bone scans to detect the fluid. So aspiration is not favored much, but previously it was done a lot. So X-ray findings, see, X-ray films are negative. That's what I was saying. You are not going to see much in X-ray films. Initial 2 to 3 weeks, you are not going to find any Codman strangle, you are not going to find any erosion, cortical erosion, nothing. It is going to be a plain normal radiograph. But if you look carefully, you can see soft tissue shadows if you look very carefully. Okay, but within 2-3 weeks, you are not going to see much. If you really want to pick up, you have to do an MRI. See, by the time there is X-ray evidence of bone destruction, the patient has already entered the chronic phase of the disease. So that we have to understand. So it takes around 10 to 21 days for an osseous lesion to become visible on a conventional radiography, because 30 to 50% reduction of bone density must occur before radiograph changes appear. So that is how infected bone will look like. Sclerotic, in between you will have lysis, around which you will have thick bone formation. So you will have mixture of sequestra and involucrum. Okay. So this is what he was telling, Codman strangle. What is Codman strangle? What is it? See, again, you guys are not understanding. You should not learn something by heart. You should understand why it is happening. Codman strangle is a periosteal reaction. That is the first thing you should understand. No one is going to scold you in the exam if you are not going to tell the proper management of a chronic osteomyelitis. They are not expecting, but you should understand what is osteomyelitis. That it is an infection of the marrow and then to the bone. That you have to tell. If you say infection of the bone and you are not able to tell which part of the bone, then nothing makes sense. That means you have just gone before the exam, eaten from the book and come next day morning. But that is what the classes are for. You should understand the basics. Book is always there, you can go home and read, but if you don't understand what is osteomyelitis, then there is no point of this class. So you have to understand this is an infection of the marrow, and because of the blood supply, it then goes to the outside of the bone, that is the cortex. That you have to understand. You have to understand, based upon the duration, you can divide it into acute, subacute, chronic. Even in the exam, if you say acute, chronic, fair enough. You should know less than 2 weeks is acute, more than 6 weeks is chronic. You have to tell the acute symptoms or the clinical hallmarks of acute osteomyelitis. You have to tell the clinical hallmarks of chronic osteomyelitis. You have to know that in acute osteomyelitis, you cannot find X-ray findings, but in chronic, you are going to find. So this is the whole reason for this class. Now the treatment and all that is already written, what microorganism, what age. So this is the periosteal reaction. Whenever any infection happens, the first thing that your bone tries to do is your periosteum to react. Why? Because that is the most biologically active layer of the bone. Your periosteum always tries to protect it. Your periosteum always tries to prevent the infection from spreading outside the bone. So a Codman strangle, though not classical of a infective feature, can be found because it is a periosteal reaction. It looks like a triangle, that's why we have called it Codman strangle. It is not a absolute necessity that you have to find it in all infective cases. But yeah, you can find periosteal reactions like this, okay. Ultrasonography previously was done. It's a very, very dicey thing to detect. It is not always the ideal investigation, but in your exam, if you are told to write a note on osteomyelitis, then you have to write clinical features. After clinical features, you have to write investigations. Investigations, you write X-ray. After that, you can put a note for a USG, bone scan. Very, very ideal thing to do, and this is the investigation of choice for acute osteomyelitis picking up. So bone scan, you know how it works? No idea. Okay. So that is again a different topic. I will, in some class, I will let you know. Okay. So the most common that is done is technetium 99M. So you give metabolite injections in the body, and then these metabolites, what they do, they go inside the whole body and they are picked up by those spots where there is infection. And that spots will come out as bright hot spots. The red, the black that you see are the spots where maximum uptake has been taken. Okay, so there are three phases, sorry, acute, subacute and chronic. You don't need to understand, that is too much for your level. Just keep in mind, technetium 99 is a sensitive imaging, bone scan, it's ideal to pick up, and it can pick up as early as 48 hours. Within 48 hours of infection, you will get it positive. So this is how much sensitive. X-rays, even 2 weeks, you won't see anything. So this is a very sensitive examination. MRI is the go-to because it is affordable. Technetium 99 scan is very, very costly. Not all patients are able to afford, and you won't get it everywhere also. So MRI is affordable, easily available, and is equally sensitive and specific also, because you will get the marrow edema. See, inside the marrow they are showing the edema. Okay, T1, T2 weighted images. See the T2 weighted images, you will see the spot. Okay. Early diagnosis. How will you diagnose? In diagnosis, how will you diagnose? I have told you all the features. Clinical features I have told you, lab investigations I have told you. So diagnosis first is, one is clinical, by seeing the patient you are diagnosing. Next is laboratory investigations, you will find total counts are raised, ESR, CRP will be raised, all the inflammatory markers will be raised. Okay. How will you diagnose else other than that? You will do imaging. You will do an X-ray. If it is a chronic, you will get it on X-ray. If it is an acute, you will do an MRI. Okay. So this is your diagnosis. Right? Let's go on. What else we have? Mori and Peterson's criteria not needed. Peltova, Van Evans not needed. Differential diagnosis. This is what you have to write in exam. So once the diagnosis is come, after that you have to write what else can be a similar features. Most common is tuberculosis in our country. So you have a lot of patients which were misdiagnosed as osteomyelitis, and later when we send the sample for biopsy, the bone for biopsy, tissue for biopsy, it came to be TB positive. Okay. So it's a very close diagnosis is tuberculosis. Okay. It can be a soft tissue infection, and rare cases, very, very rare, you can get a malignancy also, Ewing sarcoma. Okay. So these are how these things also, because all these are very, very closely related things. So it is not always that if you see the thing and you say that, oh, this is osteomyelitis. You cannot say. You have to complete the imaging, and you have to, if you're suspecting, always go in, take a tissue for biopsy, take a soft tissue, take a bone, send it for histobiopsy, histopathology, and then your pathologist will come and give you a report. If it is an infection, you will get infective features. If it's tuberculosis, you will get tuberculosis features. Okay. Treatment, not today. Treatment is another day. Bolo, what are any doubts regarding acute and chronic? Treatment is a huge thing that we have to cover it separate class. A lot of things are there, treatment. So today's class, I just wanted to tell you what is osteomyelitis, what are the types of osteomyelitis, acute, chronic, what are the clinical symptoms, what are the clinical hallmarks of acute osteomyelitis, and how to differentiate it from chronic osteomyelitis, and what are the clinical features, what are the laboratory diagnosis, and how you are going to investigate. Okay.